morning, everyone. My name is Dr. Quiroz, and I will be presenting on behalf of my group on sonographic predictors of obstructive defecatory dysfunction. So obstructive defecatory symptoms are present in up to 9% of women, and symptoms can include straining with bowel movements, splinting, and a sensation of incomplete emptying. Risk factors are largely undefined, but are thought to include both anatomic and functional disorders of the pelvic floor. Anatomic abnormalities associated with ODS include perineal descent, rectocele, and intussusception. MRI studies have mixed results regarding the defecatory dysfunction and the relative value of levator ani deficiency in this. Defecography studies have suggested an association between obstructive symptoms and a widened anorectal angle. However, some of these studies have been small and included a substantial proportion of women with other abnormalities, such as intussusception. The purpose of the study was to evaluate the relationship between ODS and levator ani deficiency, levator plate descent angle, anal rectal angle, and minimally levator hiatus. This was a retrospective study of women who had undergone 3D endovaginal ultrasound from January 2010 through November 2012. ODS women were those with affirmative responses to questions 4 and 8 on the CRADI scale, corresponding to obstructive defecation, and who reporting using at least one method of splinting as a compensatory aid for rectal evacuation. A group of comparison was chosen with women without ODS. This resulted in 100 patients randomly sampled and categorized into two groups, 48 patients with ODS symptoms and 52 asymptomatic subjects. Ultrasound images were reviewed and evaluated for the ultrasound findings as mentioned. Exclusions including that of CNS disorders such as MS and diagnosis of intussusception on ultrasound. So what do we mean by LAD? This is an example of one of our current publications, and let me just try to orient you over here. From what you can see, this is a typical image of the levator obtained using the BK2052 probe. The view is in the actual image, and highlighted in yellow for you is the puboanalis muscle. Highlighted in purple is the pubovisceralis, and lateral to that in red is the puborectalis. The transducer itself is inside the vagina labeled T. Anteriorly, you have the urethra. Posteriorly is the anus. And above that is the pubis symphysis. This slide shows a scoring system employed in one of our previous publications with the different scores labeled on the different muscles. 0 corresponds to a perfectly visualized muscle. 1 corresponds to less than 50% muscle loss, corresponding to minimal damage. Major defect corresponds to number 2 over here, with greater than 50% muscle loss, and 3 corresponds to complete absence of the muscle. The anorectal angle was measured from the sagittal view after the 3D volume can be rotated to the sagittal side. And this is a representative image and can be shown here for your reference. As you can see here, the anorectal angle shown was 159 degrees, where the vaginal transducer is in the vagina. Anteriorly, you see the urethra. Recently, we have published on normative data for this kind of methodology of measuring the ARA, and the mean ARA for patients without any symptoms and nulliparous patients is approximately 156 degrees, plus or minus 10 degrees. Now, the MLH is also known as the smallest fibromuscular dimension for the pelvic floor outlet, and is thought to be made out of the levator muscle fibers. It is measured along the puboanalis muscle, and as I previously mentioned over here, it's highlighted in yellow. And the pubic bone anteriorly and the levator plate posteriorly. After identifying the MLH, we located the shortest distance between the pubic symphysis and the levator plate, which formed the anterior-posterior diameter of the MLH corresponding to the H line on MRI. Again, recently published normative data for this includes that of a mean MLH of 13.4 centimeters square, plus or minus 2 centimeters. An ultrasound reference plural line has been published recently, and that means a pubic levator ultrasound reference assessment line, which is a line drawn through the AP axis of the midpubic symphysis and extended posteriorly. The 3D volume is then rotated so that the pleural line is vertical, and the relative position of the MLH to the pleural line was measured using an angle termed LPDA, levator plate descent angle. Again, recent publication of normative data for this angle is approximately 16 degrees, plus or minus 8. The summary statistics were calculated for this population and compared using students' t-tests and chi-squares. Multivariable logistic regression was used to determine the association of obstructive defecatory symptoms and sonographic measures of interest. Two-sided p-values of less than 0.05 were considered significant. This is demographic information for our population of interest, and what you can see here is that the mean age was approximately, for our population, was 54, with approximately 94% of our women were noted to be white, with a median parity of 2. There were no significant differences in the posterior stage of prolapse between the groups. There were no significant differences in the levator ani deficiency, and as far as the mean MLH scores also. The proportion of patients with a widened ARA was significantly greater in the ODS group. Similarly, ODS patients had a significantly greater levator plate descent angle compared to patients without ODS. That's highlighted for you here in yellow. This relationship held in the multivariable regression model, where an ARA and LPDA were included in the final model. Patients with an ARA of greater than 170 degrees had 7 times the odds of having ODS compared to those with less than 170. Patients with an LPDA of less than 9, corresponding to greater levator plate descent, had 3 times the odds of being symptomatic compared to those with less levator plate descent. In conclusion, LPDA and ARA are highly associated with obstructive defecatory symptoms. Evaluation of these structures provides additional information as to the etiology of defecatory dysfunction. Additional studies are needed to evaluate whether the effect of these parameters on therapeutic options and patient outcomes will be relevant clinically. Thank you.
Can I just ask briefly, before we take questions, have you had an opportunity to compare your findings on ultrasound to defecating proctography? Because presumably, if these patients had symptoms, they would have been investigated by the coloproctologists.
So I think I heard your question, meaning have we had the opportunity to compare the proctography findings with our ultrasound findings? And the truth is that proctography and defecography is not commonly practiced in our institution. That was largely initially substituted by dynamic MRI, and subsequent to that, we started to use ultrasound. We have an ongoing study looking at the effects and the differences between comparing ultrasound to dynamic MRI. That study is getting ready to be prepared within the next year.
Okay, thank you.
Yes, please.
Well, in fact, you don't need the coloproctologist. You don't need defecography. You don't need dynamic MR. All you need is the 3.5 to 5 megahertz curved array on your BNK machine. Just put it on the perineum and get the patient to strain. And you're going to see the commonest cause of obstructive defecation in the women that we see, which is rectocele. I bet my bottom dollar there's like 30-40% in this group that have a true rectocele on ultrasound. You just got to get them to push. That's all it needs, Valsalva. And then, of course, your results are perfectly plausible. They're absolutely plausible. I believe everything. It's just that, why is this? Come on, think about it. Why are those findings so highly significant? Well, because they've got a much larger hiatus, and when you get them to push, everything's going to come towards you because they have perineal hypermobility. So in actual fact, what's missing here, if you want to do the clinical exam, what's missing here is GH plus PB. ICS POPQ, genital hiatus, perineal body. And you'll find that those indices of yours are going to be highly correlated with GH plus PB because those people balloon. It's the same thing always. For God's sake, these symptoms and the symptoms of prolapse occur when you put those structures under load. You need to put those structures under load to see what's going on. And that means a Valsalva maneuver. Why don't you, I don't get it. Why don't you just put your blasted 2D probe on and get the people to push? And you're going to see the interception, you're going to see entroceal, you're going to see rectoceal, you're going to see what makes them have such problems when they sit on the loo.
So the one comment I have to say about that, Peter, is that we routinely ask patients to Valsalva and actually squeeze as well and use the 2D BK probe for that initially. As far as POP-Q values, they were compared between the two populations, and we did not see a difference between them.
I will take one more question. Dr.
Sorry, that needs a follow-up. And we all know that is completely implausible. Completely implausible, I'm sorry. Because we know that symptoms of obstructive defecation are associated with the clinical rectoceal. Come on, let's not doubt the obvious. If somebody's got a third-degree posterior compartment prolapse, most of those people have symptoms of obstructive defecation. So that makes me doubt the likelihood of true positive and false positive and false negative clinical
Hans-Peter,
exams.
can we give someone else a chance, please? Andrea.
Anytime, Linda.
Thank you.
Andrea Tubaro, Rome, Italy. How much do your angles depend on patient position, standing versus lying?
From what I think I heard from the question, it was if I heard standing versus lying. If there was a difference in the position and whether we saw a difference in that. And the truth is that these patients were examined in the lithotomy position. They were not examined in standing or lying. I mean, just in the lithotomy position, so basically lying down.
Thank you very much.
Thank you.